Good afternoon. This presentation focuses on the eating disorder bulimia nervosa, also known as BN for short, and fluoxetine/Prozac. This is what the DSM says regarding the uh, symptoms. The central feature of bulimia is binging, in other words, uncontrolled eating, which are followed by behaviors intended to prevent weight gain from the binge eating. The diagnostic criteria is as follows. Recurrent episodes of binge eating. An episode of binge eating is characterized by both of the following. One, eating in a discrete period of time within, say, 2-hour period, an amount of food that is definitely larger than what most people would eat during a similar period of time and under similar circumstances. A sense of lack of control over eating during that episode. Uh, for example, a feeling that you cannot stop eating or control what or how much you are eating. Recurrent inappropriate compensatory behavior to prevent weight gain, such as self-induced vomiting, misuse of laxatives, diuretics, or other medications, fasting, or excessive exercise. The binge eating and inappropriate compensatory behaviors both occur on average at least once a week for 3 months. Self-evaluation is unduly influenced by body shape and weight. Binging or purging does not occur exclusively during episodes of behavior that would be common in those with anorexia nervosa. Regarding prevalence, the average onset for bulimia is 18 years old, though it can begin in the early teen years. The lifetime prevalence rate in the U.S. is approximately 0.5% for men and 1.5% for women, with some reports suggesting it to be as high as 3% among women. Men with BN are more likely than women to use excessive exercise to control their weight, as they tend to be more focused on achieving a lean, muscular look. In the U.S., BN is more common among Caucasians and African Americans and is far more common in westernized cultures than in non-westernized cultures. The prevalence of BN increased significantly in the second half of the 20th century and has remained high despite the fact that there has been an increased availability of effective treatments. Though the death rate for those with BN is less than those with anorexia, the death rate for those with BN is almost double the rate of the general population due to the additional medical complications associated with the disorder, one of the main issues being the loss of electrolytes due to purging. The suicide rate is 7.5 times greater for those suffering with BN than the general population, and bulimia is more prevalent than anorexia and has a better prognosis. Also, it is not uncommon for someone with BN to actually have a normal weight or even be overweight. Regarding heritability, genetic studies indicate that approximately 50 to 80% of a person's risk of an eating disorder is due to genetic factors, particularly among those with a family history of mood disorders, substance abuse, and low self-esteem. History of some treatment approaches. Because of the fact that BN was not specifically identified and categorized until the late 1900s, there really is not a long history of treatments specifically targeting BN, though there is evidence that suggests that binging and purging were popular in certain ancient cultures. This practice was not necessarily seen as abnormal, therefore it would not have fallen into what we would categorize today as being a disorder. Bulimia was named and first described by the British psychiatrist Gerald Russell in 1979. BN was not recognized as a separate disorder until its addition to the DSM-3 in 1987. Now, having said that, there was some attention given to eating disorders in the early 1900s. And if you would have told me this, I would have thought you were kidding me. But believe it or not, there was something called a parentectomy, which was considered an appropriate treatment for eating disorders well into the 20th century. Essentially, a person with an eating disorder would be separated from their parents as a cure. It was believed that mothers were the primary cause of the eating disorders of their children. The typical treatment instructed parents to step aside and turn their children over to the individual treatment or residential treatment centers, an approach that healthcare professionals now believe in many cases was detrimental to both the families and the patients. Today, the cause is more likely to be attributed to genetic factors. As a side note, personally has been my thought for a long time that some of what may be labeled as genetic might be closer to learned behavior within the family system, but we don't have time to explore that in this presentation. We'll save that for another day. Brief overview of some common psychotropic and non-pharmacological treatments. In the early 1980s, TCAs were investigated in a series of double-blind, placebo-controlled trials for use in the treatment of bulimia. Imipramine was the first antidepressant demonstrated to have a statistically significant advantage over placebo in reducing the frequency of binge eating and purging behaviors. Imipramine was discovered in 1951, was introduced for medical use in 1957. Imipramine, the brand name being Tofranil, and the other TCAs have decreased in recent decades due to the introduction of the SSRIs, which have fewer side effects and are safer as it relates to overdose. Today, an SSRI would be a drug of choice for BN. Eating disorder treatment now encompasses a holistic model that addresses multiple approaches that would include medical, psychological, and nutritional. This includes acceptance and commitment therapy, ACT, as well as CBT and DBT. Clinicians also focus on caregivers and support systems as the agents of change and healing through their commitment to a variety of family treatment methods, which include family systems, family-based treatment, and emotional focused therapy, family therapy. In addition, clinicians provide patients with information regarding nutrition and health and the promotion of a positive body image. Psychological tests, this is something out of the Patter textbook, are also used, including the eating disorder specific psychometric test, eating attitude test, body attitude questionnaire, eating disorder inventory, and the SCOFF questionnaire. In my readings, I have found statements like, research indicates that CBT paired with the use of the antidepressant fluoxetine is the treatment of choice for BN. Other forms of treatment, I've read that there is no scientific studies on homeopathy to treat bulimia. However, there are natural treatments and solutions that are suggested at times, such as avoid caffeine, alcohol, and tobacco, drink 6 to 8 glasses of filtered water daily, use quality protein sources such as lean meat and eggs, whey and vegetable protein shakes as a part of a balanced program to gain muscle mass and prevent wasting. Also avoid refined sugars such as candy and soft drinks. Oftentimes, doctors will focus on nutritional deficiencies and suggest a vitamin with minerals, omega-3 fatty acids such as fish oil, coenzyme Q10, and probiotics for gut health. There are also a couple of herbs that are recommended, such as holy basil for stress and catnip to calm the nerves and soothe the digestive system. Many believe that massage therapy can be an effective part of a bulimia treatment plan. In my humble opinion, much of this speaks to an overarching need for a greater sense of well-being physically, socially, and mentally, which would also speak to the importance of the need for a healthier spiritual life, all of which would be, of course, culturally acceptable. So the medication in review here, this medication I'm focusing on today, as I said, is fluoxetine, brand name known as Prozac, which is an SSRI class of antidepressants. Fluoxetine appeared on the Belgian market in 1986. In the US, the FDA gave its final approval in December of 1987, and a month later, Eli Lilly began marketing Prozac. Annual sales in the US reached $350 million within 1 year. The role of fluoxetine is to target the imbalance of serotonin levels in the body that can increase urges to binge and purge in people who have bulimia. And antidepressant medications, particularly fluoxetine, can decrease these urges by effectively balancing the levels of neurotransmitters in the brain. People with bulimia often respond to SSRI antidepressants even if they aren't depressed. Not a requirement. Fluoxetine can help people stop binging and purging when used alone or with psychotherapeutic interventions such as CBT. In fact, and this is one reason why I chose this, I had selected fluoxetine. I had no idea what the disorder would be, but I read that fluoxetine is the only antidepressant approved by the U.S. Food and Drug Administration for the treatment of bulimia, which I found to be very interesting. Regarding pharmacokinetics, I know that word, absorption in humans following a single oral 40 milligram dose peak plasma concentrations of fluoxetine from 15 to 55 nanograms per milliliter are observed after 6 to 8 hours. Food does not appear to affect the systemic bioavailability of fluoxetine, although it may delay its absorption by 1 to 2 hours, which is probably not clinically significant. Therefore, fluoxetine may be administered with or without food. Regarding distribution, over the concentration range from 200 to 1,000 nanograms per milliliter, approximately 94.5% of fluoxetine is bound in vitro to human serum proteins, including albumin and L-glycoprotein. Fluoxetine is a racemic mixture 50-50 of R-fluoxetine and S-fluoxetine enantiomers, each of a pair of molecules, which enantiomers are a pair of molecules that are mirror images of each other. In animal models, these enantiomers are specific and potent serotonin uptake inhibitors with essentially equivalent pharmacologic activity. The S-fluoxetine enantiomer is eliminated more slowly and is the predominant enantiomer present in plasma at steady state. Regarding metabolism, fluoxetine is extensively metabolized in the liver to norfluoxetine and a number of other unidentified metabolites. The only identified active metabolite, norfluoxetine, is formed by demethylation of fluoxetine. In animal models, S-norfluoxetine is a potent and selective inhibitor of serotonin uptake and has activity essentially equivalent to R or S-fluoxetine. R-fluoxetine is significantly less potent than the parent drug in the inhibition of serotonin uptake. Elimination, the relatively slow elimination of fluoxetine, elimination half-life of 1 to 3 days after acute administration and 4 to 6 days after chronic administration, and its active metabolite, norfluoxetine, leads to significant accumulation of these active species in chronic use and delayed attainment of steady state, even when a fixed dose is used. After 30 days of dosing at 40 milligrams per day, plasma concentrations of fluoxetine in the range of 91 to 302 nanograms per milliliter and norfluoxetine in the range of 72 to 258 nanograms per milliliter have been observed. Plasma concentrations of fluoxetine were higher than those predicted by single-dose studies because fluoxetine's metabolism is not proportional to dose. The primary route of elimination appears to be hepatic metabolism to inactive metabolites excreted by the kidney. So other things that can be treated with fluoxetine. First would be OCD, obsessive compulsive disorder. For adults, 20 milligrams taken orally daily. Initially, consider a dose increase after several weeks if insufficient clinical improvement is observed. The full therapeutic effect may be delayed until 5 weeks of treatment or longer. The recommended dose range is 20 to 60 milligrams per day. For older folks, listed as geriatric, a less frequent or lower dose should be considered. The maximum would for anybody that I've read with any disorder would be 80 milligrams per day, but never starting out at that point. Daily doses. So if you have daily doses greater than 20 milligrams per day, they can be divided into 2 doses per day. For children 7 years and older, 10 milligrams per day orally initially. Dosage may be increased after several weeks from 20 to 60 milligrams per day orally. For children 3 to 6 years old, a limited data is available, but there's some suggestion that you should start out with 5 milligrams per day, followed by gradual increases based on response to a range of possibly 15 milligrams a day. It can also be used for the treatment of panic disorder with or without agoraphobia. Adults would start at 10 milligrams a day, increase it to, after 1 week, to 20 milligrams per day. After several weeks, you may increase further if clinical improvements not observed. Regarding geriatric, less frequent, lower dose, again, not to exceed 60 milligrams a day. Go slower in the titrating. Higher doses have not been studied in panic disorders. In clinical trials, the most common dose would be 20 milligrams per day. For children 8 years old and older, starting at 10 milligrams per day. The median time to attain improvement is typically going to be about 7.5 weeks. Can also be used for women who have PMDD, premenstrual dysphoric disorder. Initially, an oral dose of 20 milligrams per day, given continuously or during the luteal phase, starting daily dose 14 days prior to the anticipated start of menses through the first full day of menses, and repeating with each new cycle. In clinical trials, doses of 20 to 60 milligrams were effective, although 60 milligram dose did not provide any additional benefit. Doses above 60 milligrams a day have not been evaluated for PMDD. For things like MDD or GAD, again, adults start at 20 milligrams per day orally. You may increase the dose after several weeks by 10 to 20 milligrams as needed and tolerated. For older people, again, less frequent, lower dosage should be considered. For geriatric adults, generally acute episodes of depression require several months of sustained pharmacological therapy. Children and adolescents 8 to 17, again, 10 to 20 milligrams orally per day. Usually effective dose is 10 to 20. However, it can be increased. May take 4 weeks or longer. The maximum dose should not be above 60 milligrams. Can also be used to treat autism. For adults, although data is limited, fluoxetine may be useful for autistic patients with coexisting OCD or depressive symptoms. Again, dose ranges from 20 to 40 milligrams per day. For children 2 years and older, 2.5 milligrams orally, titrated up based on weight and tolerability to a maximum target dose. That just has to be monitored with somebody that young. And again, it could take, this is all very individualized. I mean, I've had to edit a lot out of here, but basically it all has to be very, very individualized and very much monitored. Then for bulimia, the initial and recommended dose is 60 milligrams by mouth once daily, administered in the morning. In clinical trials, doses less than 60 milligrams per day were not effective in reducing binge eating and vomiting. For some patients, including geriatric adults, it may be necessary to titrate up to the dosage over several days. Doses above 60 milligrams per day orally have not been systematically studied in patients with bulimia. And as it relates to children and adolescents 12 years and older with bulimia, 20 milligrams per day initially, titrated up by 20 milligrams per day every 3 days to a maximum dose of 60 milligrams per day would be the suggested dose. In one small study of 10 adolescent females with a diagnosis of BN, this regimen was associated with significant decrease in the core behavioral symptoms of binging and purging, and was used along with supportive psychotherapy. Although further research is needed, the study was consistent with the known effective dose for BN in adults, which is the 60 milligrams per day. Fluoxetine is also used for PTSD, anorexia nervosa, obesity, borderline personality disorder, fibromyalgia. And again, the dosages for these disorders are consistent with the others that I've listed, with the starting dosages ranging basically in the 10 to 20 milligrams per day, increasing over time until the desired effect is achieved. Prozac is a selective serotonin reuptake inhibitor, SSRI. It works by blocking the absorption of the neurotransmitter serotonin in the brain. Regulating the amount of serotonin helps the brain cells transmit messages to each other. This results in a better, more stable mood. It also results in more neurons being present in the region of the brain called the dentate gyrus, part of the hippocampal formation. Prozac is intended to help patients feel more relaxed, less anxious, improve sleep and appetite, help stimulate a greater interest in life, provide increased energy, help improve focus. In a nutshell, Prozac helps those who suffer from bulimia nervosa by reducing depression and anxiety, which can lead to improved mood. To me, because of the focus on mood, this indicates the importance of using psychotherapy in conjunction with medication. The likely side effects, the list, quite frankly, of side effects would keep us here all night. That's just blew my mind when I saw the entire range of them, but a few of them: decreased libido and sexual dysfunction, anxiety, nervousness, abnormal dreams, sweating, diarrhea, asthenia, which is a lack of bodily strength, skin rash, tremors, flu syndrome, insomnia, drowsiness, sinusitis, painful or difficult digestion, dry mouth, nausea, vasodilation, which is widening of the blood vessels, suicide, weight gain, and aggression. It is advised to avoid abrupt discontinuation of fluoxetine if possible. Gradual tapering is recommended during discontinuation of any SSRI to decrease or prevent the occurrence of potential withdrawal symptoms. However, withdrawal symptoms have been reported less frequently with long-acting SSRIs, such as fluoxetine, compared to shorter-acting SSRIs. Also, sudden reduction or complete termination of Prozac can result in any number of the above listed negative side effects. Okay, regarding major studies, there was a study conducted in 1992. It was a double-blind, placebo-controlled study by Halmy et al. 382 female patients were randomly assigned to receive fluoxetine or a placebo at doses of 20 milligram or 60 milligram daily for 8 weeks. Treatment with the lower dose of 20 milligrams of fluoxetine resulted in reductions in binge eating and vomiting compared with the placebo. The results being for binge eating, the fluoxetine reduced it by 45% versus 33% in the placebo. For vomiting, fluoxetine reduced it by 29% versus 5% for the placebo. For those that received 60 milligrams of fluoxetine, which is really the recommended dosage, they had greater improvement with a 67% reduction in binge eating and a 56% reduction in vomiting. Fluoxetine was approved for use with bulimia in 1994, 2 years after that study. Another study, in the year 2000, the study began, and then it was completed in 2005, so 5 years, which compared the best available treatment for BN, which the researchers identified as being CBT augmented by fluoxetine, if indicated, with a stepped care treatment approach in order to enhance treatment effectiveness. The aim was to establish the relative effectiveness of those two approaches. The method was that it was a randomized trial conducted at 4 clinical centers. A total of 293 participants, all adult females with BN, were randomized to one of 2 treatment conditions. So the first group received manual-based CBT delivered in an individual therapy format involving 20 sessions over 18 weeks. Participants who were predicted to be non-responders after 6 sessions of CBT had fluoxetine added to the treatment. With the second group, they received a stepped care approach that began with supervised self-help, with the addition of fluoxetine in participants who were predicted to be non-responders after 6 sessions, followed by CBT for those who have failed to achieve abstinence with self-help and medication management. The results that they reported, there were no differences between the 2 treatment conditions in inducing recovery from binging and purging, which for them meant no binge eating or purging behaviors for 28 days, or remission, which would mean that their condition no longer met the DSM criteria. However, at the end of 1 year, and this is the important part, After a 1 year of follow-up, the people that received the stepped care treatment, they were significantly superior results to CBT alone. So the self-help meant a whole lot. So the conclusion that they came to, that therapist-assisted self-help was an effective first-level treatment in the stepped care sequence, and the full sequence was more effective than CBT, suggesting that treatment is enhanced with a more individualized approach. Bottom line, the addition of self-help training improved treatment outcomes. This would be important to a therapist, in my opinion, who can assist with a self-help approach. Spiritual implications. In my view, there's no conflict between using a medically prescribed medication and a person's free will, provided that the patient was given full disclosure regarding the benefits and potential side effects of a drug. It would be a matter of free choice on the part of the patient as to whether they used the drug or chose not to use the drug. And the important part to me is that I just don't see that using a medication would ever indicate a lack of faith. Implication for the MFT, my thought is that one of the most important implications for MFTs is having the discernment to know when psychotherapy alone may not be sufficient in helping a client resolve their issues. It would be important to know when to make the decision to refer the client to another mental health care professional to determine if medication is appropriate, and then reflecting back on that one study as it relates to MFTs, really the power of therapy. It's really important and meaningful. Thank you for listening, and have a great day. Thank you.